Alrighty, well, thank you all so much for joining us today. My name is Melanie Harris. I'm a strategy director at Complete College America, and I'm honored to be hosting and co-facilitating our Student Basic Needs webinar series with the Kentucky Student Success Collaborative. A few quick short notes for Zoom. You are muted for the duration of the presentation section of today. We will have time later on for y'all to unmute and turn your cameras on and engage with one another. So please keep that in mind. Please use the chat. You can send messages, ask questions to our phenomenal presenter today, and we'll capture any resources or information shared there, and we'll share it back out with you. Today we are recording, so you'll receive a link to the recording shortly after today's session. And so I want to turn it over to my friend Lily to open us up today.
Right. Welcome, everyone. We're so glad you can join us. My name is Lily Massa McKinley. I'm the Executive Director of the Kentucky Student Success Collaborative. And we launched this last October, and we have been busy running around and visiting various campuses. So hopefully we've been to yours. If not, I'm sure we're coming soon. But one of the first things that was really brought up on our campuses as a high priority and a significant challenge was around student basic needs and the support, the non-academic challenges and barriers that students were facing outside the classroom. And among those, mental health has really risen to the top of concerns. And so we are really thankful that we were able to partner with Complete College America and their vast network of experts on these different topics related to student basic needs in order to provide this webinar series to our campus partners. Throughout today, we're going to hear from our expert speaker, and then we will have time at the end for breakout rooms where we'll get to talk to one another about what's going on and, thinking about the strategies and ideas that are shared in the session. What would that look like on our own campuses? So just a little bit about the collaborative as we get started. Let me see here. Our focus is really helping build the capacity of our campus partners to accelerate change. And that is also based on your own priorities and the work that you have ongoing around student success efforts. We really believe that we can do more together than any of us can do individually. And so a part of our focus is bringing campuses together to have these collaborative conversations. So we are conveners, facilitators, and then we also, when we really identify an area of action, we want to be that backbone support that really helps move the ball down the field or helps our campuses make progress in an accelerated fashion. A few of the things that we do, we convene communities of practice on topics that are of interest and importance to our campus partners. We have recently launched the Impact Exchange, which is an online, it's a virtual knowledge and resource hub where campus partners can ask questions to one another, share ideas and resources, attach documents or research and toolkits and playbooks that are really helpful. Inside the Impact Exchange, we actually have a channel dedicated to student basic needs, and there's quite a few resources that are inside there. And after this workshop, we will be posting all of the resources and the recording to the Impact Exchange for you to view now and in the future. We do offer professional development. We're working with national partners such as JFF, Jobs for the Future, and Complete College America on different technical assistance initiatives in the state. And also throughout all of our different work, we are focused on embedding change leadership and change management principles, approaches, and strategies into the change that we're trying to lead. So we're just glad to be able to work with you and hopefully offer some support to your various campus initiatives. That is all that I have.
Well, thank you, Lily. I think y'all are doing great work. So it's always so good to hear what y'all are working on. So it is my honor to introduce our speaker for today, Dr. Makeda Dougherty from Georgia State University. She's the Director of Counseling Services and is here to share all of her great insight into mental health services and how we can scale that in Kentucky. So I'll turn it over to you, Dr. Dougherty.
All right. Hey, everybody. It's afternoon. Good afternoon, everybody. Thanks for joining me for the talk. I'm going to take a second to share my screen. I made a little brief presentation, and then we'll talk questions. Feel free to chat. I'll try and make sure I'm checking it out. That's not my best skill, but I'll go for it. All right, give me a second. All right, can everybody see that? Can you also see your faces? How about now? All right, so my topic today is
We can
innovative
still see
ways-
all of our faces.
You can?
Yeah.
How's that?
We can see your screen. You can keep going.
Well, I can't see the screen. Maybe it's me. You're right. My bad.
Okay. I'm like, uh-oh. Okay. My topic, innovative ways to scale mental health services and support. And as was said, I'm the Director of Counseling Services at Georgia State. I'll just get into why I think this is an important topic or why I've been asked to talk about it, and then say a little bit about myself in my journey with the Counseling Center. And hopefully that'll give some context to the rest of the strategies that I will be sharing. Okay, so some of you on the call may be all affiliated with counseling, and for those of you that aren't, we've got a problem. We're in a situation. There's an increasing demand and reliance in universities to address student mental concerns, health concerns. We are the ones that people call when the students write faculty with concerning notes talking about suicidal ideation. We're the ones that people call if someone has a gun and is walking around campus. The police still give us a call. If there's a death on campus, people give us a call. And so we are relied upon on campus. The thing about it is the Counseling Center cannot meet all the mental health needs of all university students. And I'll say a little bit more about Georgia State. Georgia State has 55,000 students and we've got 6 campuses. There's no way that our counseling center can manage the mental health care of all students. However, when students come to university, they come often and parents often come expecting that the counseling center can take over for either mental health care that they've already been engaged in or the mental health care that they may need. There's also another trend in that there is increasing acuity of mental health presenting problems by those demanding the services. I haven't always been involved in the counseling world, but I have been involved long enough to hear the arguments to see that college counseling wasn't what I thought it was going to be when I joined. I used to work in the VAs, and I used to work at a trauma level 1 hospital, leading a research team and a clinical team. And college counseling was not something that I knew about in detail. I was a program evaluation person, and I originally came to Georgia State as a contract counselor because I wanted clinical hours. I'm a psychologist, I miss seeing patients, and that's how I got there. But one thing that stood out to me was, this is not what I thought I'd be talking about in the college counseling center. Students have real problems. This is the time where mood disorders, bipolar, psychotic symptoms are going to break. This is the time where students are, if they're not experimenting with substances or they have already had a substance problem, this is going on, particularly at Georgia State. One of the things that unites the student body, the diverse student body, is that 60% are Pell eligible, which means their families fall below the poverty rate. Given the financial duress, I believe, and that 80% of the students are commuter students, the problem sets are more complex and often involve other people in terms of family stress, and there's a lot of trauma amongst this group. So that's fine if we didn't have the problem. The financial support is capped. Our resources, we only have so many resources. Georgia State's health fee is $40. The 28% is a typo. We're over 100% charging less than other research universities in the state. Every university charges at least $100 or more for their health fees. So there's only so much we can do. Also, the health fees don't just fund some of our counseling services, but the health clinic and health promotions. And those things, that especially the health clinic, are expensive. And I'll scoot back to tell you a little bit about myself too, and that I've been here and trying to make the case for we need more resources. In that, one of the things that we're compared against is the accreditation. So IACS, our accrediting body for counseling centers, and they recommend a 1 to 1,500 ratio counseling staff to students. Ours is about 1 to 5,000. And in order to get to 1 to 1,500, we'd have to have at least 37 FTEs, full-time employees, who are providing primarily clinical service hours. There will never be the money to do that. And particularly with increasing demand, we just have to be increasingly hiring. And that is not really a feasible or viable option. Currently at Georgia State, I'm maxed out with the budget, not all just with counselors, but my budget is maxed out. We have 16 FTE. So there's a big gap in where we're doing. All right, how do I do it? So in thinking about what I was asked to do, let's talk about scale. Well, what does scale to scale? What does it actually mean? It can mean a couple things, or quite a few things, but most of the definitions converge around you want to design something or adjust it to the size to be complementary or representative of the size of something else. Maps need to be the scale. So anyways, so if that's the case, the challenge that we then have is, how do we adjust service offerings so that support is available to meet most students? And how do we make sure that those services are accessible to the most students? The other scale issue is, how do you increase your services or what you're doing without necessarily an equal increase in resources? And so what that challenge involves is, how do we maximize the services and accessibility using available resources and technologies that we have? And so those three things are going to be what I'm talking about, largely from my own experience at Georgia State. Before I go into the strategies that I want to share with you, as I said, I came in as a contract counselor. At that time, there was a reorganization in the center. All the staff were riffed, and there was a director, and she was able to hire a few contractors in order to see the students who were already coming to the center. It was quite a surprise. Because I felt for the director and her mission, which she said is she wanted to provide the most care to students, and what was happening wasn't right. I believe before I came, according to the data, they were seeing about 200 students a year. Hold that till I show you what we've been doing since those years. That was back in 2012. I asked the director, could I be helpful? She said, sure, deal with the wait list. I started to deal with the wait list. I was involved with scheduling. I moved up because of my background in research and program evaluation to the coordinator, to the associate director, to the director now. We've had staff challenges. I mean, and we've built the staff from the ground since I've gotten there. And so I've even spent time in the front office. I've worked every job in this center. And so this is what informs the strategies that I have. These are the strategies that we came to, or that I came to use over the time of trying to figure out, how do I offer enough, make it accessible without a lot. All right, expanding the box. Traditional counseling, when I think of traditional counseling center, you think of group therapy, individual therapy, maybe they do some outreach. Other services, but those are that's the meat, the bread and butter. So if we're going to be building something to scale, how can we shift the way we think about what the counseling center does and how is it structured? The things that guided us in figuring out how do we expand our box is, one, by being truly student focused. Given our population, what does that mean we need to offer? How does that influence who's offering it and what modality it's being offered from? The other big thing is, how do you offer services, or to offer services that support varying levels of need? As I said, we'll talk about that in a moment. The last thing in this section is, how can you expand services without increasing the administrative load that the center already has? And one of our strategies has been to use third-party services to expand what we're able to offer. Okay, so first strategy in expanding the box. When I talk about population-centered, we are a majority minority school. We have, I think, 70% are BIPOC status. And what we know is that often those populations aren't the ones who are utilizing traditional counseling and are not as likely to go to participate in counseling as their white counterparts. We also know that some populations have a particular stigma, about what does mental health even mean, if it's a thing, and if it should be if you should attend to it. So one of the things, the first thing in terms of thinking about this is one thing. So I was building. I want to say the statement is, if they build it, you build it, they will come. And that's not quite true. There's some nuance to it. So one of the things we did is, even though it was already built, there's a counseling center, people weren't coming to it. Like I said, they were seeing about 200 people, new students a year. What we did is increased outreach efforts outside of this center that were particularly talking about mental health. We had stickers that we would put on the window, on the mirrors, saying it was okay to ask for support. We went and talked to student groups, we tabled, we talked specifically to the Black Students Association, the fraternities, the athletes, the different already intact groups. And if you want to have equitable services and access, then you have to actually target the people you know are less likely to come and make the services relevant to them. And part of that is having them understand that helping students to think that they want to come to you because there's a chance you could understand them. And part of increasing that understanding or belief in the chance that you might be able to help them is to hire staff or have staff that look like them. That for us means hiring intentionally a diverse staff. diversity in race, diversity in religious affiliation, diversity in sexual orientation, and diversity of thought in terms of approach. Given the diversity of students, everybody works differently. And so I also thought it was important to also have diverse staff in the way that they approach problems. A lot of centers or clinics might have, we do CBT here and that's what you have to do. That I don't believe that hasn't been our strategy at Georgia State. And I think you'll see what it's turned out to be for us. This is strategy number 2. Strike while the iron is hot. They may not come back. And what I'm talking about here is in 2012 or 13, we implemented drop-in services. Before the center, you would have to call to make an appointment. To make an appointment to have an assessment. Then they would come to the assessment. And after that, they would have to wait until the counselors did a case management meeting or where they assign people to the counselors. And then the student would get a call back about, okay, you've been assigned to a counselor. In that, by looking at the data, we could see that 70% of students didn't finish that process out. There was too much lag time between when they called and when there was something available for them. So one of the things that I think is has really driven a lot of the other services that we offer, largely because of the increased demand. As you can see on this chart, we've, over the years, had 109% increase in students presenting to the Center for Services within 6 years. This drop here at the end is during the pandemic year where we were all virtual. But even with that, the 15,000 students seen, we did, 1,500, we did about 15,000 appointments. So the reason why this is important is because research, what we know about is teachable moment. When students are ready, that's when you're most likely to get behavior change. Students are also ambivalent about approaching, and if you make them wait, they will leave. The other thing is that given that presenting concerns are, or students are having more serious problems, 60% of the students that come to our center have expressed suicidal ideation at some point in their lives. So another thing that is helpful in general about offering same-day consultations with a therapist is that it helps the centers and the school's liability. If a student comes to the center and gets turned away, or they make an appointment for a week later, but it turns out they committed suicide in the middle of that week, is there something that the counseling center could have done? And we say, yes, we could have assessed them the day they presented to the center, and to see what did they need support with, and what is their risk level at that time, and can they wait for assignment, or can't they wait for assignment, or do they need to be hospitalized at that time? So the other thing about this is, like I said, one of the things that counseling centers has an issue with is the gap in time between a student presenting and a student getting services. In order to do that, we've streamlined our referral process to minimize that gap, and also to minimize that gap. And the way we do that is the day that the student is seen, they receive a referral that's sent to our scheduler, and either depending on their level of need, they will be scheduled in a certain amount of time. But that communication happens immediately. We also offer virtual and in-person services, which is something else that is access, that increases access. There's some students who prefer in-person. There's certain students who can't make in-person, who make it easier for virtual services. So if you want to increase access, you want to have the widest menu of options to choose from. Address varying levels of concern. So what's the issue? Well, students are presenting in all kinds of ways. So how could you possibly address all levels of concern? Some students are coming in who want ongoing individual therapy. Some don't. Some aren't in the scope of the center. Some can do our scheduling rubric. Some need more flexibility than that. Some students don't want to talk to a counselor but need to. Some people are never going to talk to a counselor even though they could use it. Some people just need emergency support. Some people need to go to the hospital right now. And some people only want to see counselors that meet these certain qualities. So given the varying levels of need, what can we do to address that? At our counseling center, these are our core services. So one of the things we do to address that is offer core services, but also have tiered services. I'll say more about these. The tiered services. If we know that most people who could use counseling aren't going to come anyways, and if we also know that everybody doesn't need counseling, but every student is going to be stressed and every student is going to get overwhelmed at some point, and everybody has mental health, either good or not so good. It's on a continuum. So what can we do to start at the front of the continuum for the students that need prevention, education, or just the maintenance of the good mental health they do have? And some of the strategies that has worked for us or that we've put into place have been a strong social media presence. That was especially heightened during the pandemic. And what we saw was over 100,000 views on some of our videos about mental health and on all sorts of videos. Check out our hashtag BeWellPanthers. We have all of the things we post on YouTube, Instagram, Facebook, Twitter, all are under BeWellPanthers. And we use graduate students and health educators to help us keep up with the amount of content that's needed to put out in order to keep students interested. We also have what I call low touch things that bring people to the center, but not necessarily to use up a clinical hour with a counselor. But what can we do to address the stress and the overwhelmment, and to also put value on the things that help rectify that, which is rest, recharge, and play. We have a relaxation room where there's a massage chair. I've invested or wrote a grant to get some biofeedback and VR goggles to help students get acquainted with mindfulness services in mindfulness practices in a fun sort of way. And this is the other piece. Let me talk about the chatbot first. The chatbot is something that the university has that sends that uses AI to send chats to the student body. We've been working with the chatbot to start You've Got This messaging. As I said, I truly believe that the counseling center has the responsibility to address support, mental health supports beyond just to those that come into the center. So in easy ways we can do this, we can send encouraging messages. Everybody likes an encouraging message, that are also linked to resources. So down at the bottom is a example of a message that we sent out to students. Hey, Panthers Pounce here. We know this time of year can be overwhelming, but you're not alone. Visit TogetherAll, a peer-to-peer chat space to get and give support to each other. And as you can see, just from that, we had quite a few students engaging, and we got good feedback from the students saying, thanks, I love you, appreciate the encouragement. These are the type of things that also let students know we do care about their mental health and that we might be relatable. And if they needed support, they may be willing to come to us later. The last thing is expanding the services that the counseling center can't or doesn't offer itself. And this is where our contracts with third-party services come in. And primarily for those in this tier 1 period, where it's not individual therapy that they're needing, it's lighter touch. So we've got a subscription to Campus Well app, which is a one-stop shop for health resources and other supports on the university together. So we work with other campuses to have this one-stop shop that leads back to our website, back to other articles and assessments for students. And that's bewell.gsu.edu. We also were granted to use this app called Driven, and it's a resilience app. If one of the things we know is that the journey is going to be hard and maintained effort is going to be needed, what can we do to help students increase their resilience skills without using up a clinical hour necessarily, because they don't necessarily need that type of care for right there. We also have a subscription for Headspace, which is a mindfulness practice app and meditation app. Cognito is also something that we started to use and got a grant for recently, which our number one outreach or request or concern on the campus is, what do I do with a stressed student? There's certain trainings that most college campuses do, like mental health first aid or QPR training, that take up that involve a trainer and several hours of time. A lot of people aren't going to be able to do that, and it's expensive. Cognito is an AI-driven training module that has been shown to be effective in helping students and staff learn how to, or practice how to have conversations about mental health concerns and how to make a good referral. And it does this through, it's pretty cool. It does it through role play and AI, where it gives you individualized feedback about how did you respond and how it might work out for the student. And those are other third-party app or third-party contract that we do is with TogetherAll. This is our tier 2. So the first tier is basically self-help and encouraging message. Tier 2 is giving students the ability to talk to each other. Most students end up talking to each other, their families, or something as an intervention anyways. So how can we reinforce this or create a space for this? We've done it through the service called TogetherAll. And TogetherAll is a peer-to-peer chat platform that allows students to chat about mental health in a positive way, give support. And a cool thing about it, or the especially special thing about it, is it's also monitored by our third-party service, who helps us with our on-call after-hour services. In the beginning, I was on call by myself for 3 years. I was interrupted every night over boyfriend, girlfriend problems, all the way up to, someone's on a building about to jump. Anyways, it's a lot to manage. However, and it became unwieldy for us to manage the number of calls that we were giving, because we were committed to also saying, hey, if services are going to be accessible, we need to have them offered after business hours. We work with a company called Protocol. Protocol, it offers crisis consultation and help in conjunction with universities. They're excellent. They've worked excellent for us. It took us selling the university on, this is something that's okay to use, but it's worked. We also offer peer-to-peer support for our CRC, which we're building, which is the Collegiate Recovery Program. The next tier is touch with a counselor, but limited. We've begun to offer not just our ongoing individual services that used to be a 15 session limit and is now an 8 session limit. And I'll tell you a little bit about why in a sec, and also offering students bridge services if they need to be referred outside of the clinic. And so again, it's making sure that you're not dropping the ball on anybody, but for students that don't want to come to 8 sessions or don't want to come to 15 sessions, and they're not going to come or need more flexible scheduling, what I was able to do, what they're able to do now through these care consultations is just drop in with the same therapist, but whenever they want. And tier 4 and tier 5 are what we normally think of when we're offering it. The next thing is to increase our process efficiencies. And this is with the second piece of to bring to scale. How do you increase without necessarily increase resources? And what I was able to do is use data to tailor our services and finally write the types of reports that got us money in the end, or just 3 years ago. I highly suggest using electronic medical records. The first thing I did when I became coordinator is I got rid of paper and folders. The EMR medical records is a much neater way of keeping data. It allows you to keep data that you wouldn't be able to keep by using a paper methods that can help you make decisions about how you offer services. One example of that is when I first started offering drop-in services, all counselors had a shift of walk-in, a 4-hour shift of walk-in. And that was a scheduling feat, but that's the way it was. By asking the students, when are they available to meet with a counselor, I was able to crunch those numbers and see when are most students saying they're available, and staff walk in at those times more heavily, given that I knew that more people were going to be available and probably come in during those times. It also let me know that I needed to maybe push back the hours. So on Tuesdays and Thursdays, we're open late. We're open till 7 o'clock because I saw that many students had availability after our 5:15 normal closing time. The other thing is we use student success and attendance rates. So when we did 15 sessions, they averaged 8 sessions anyways. I also noticed in the beginning that a lot of students were missing their appointments, which was elongating how long we were, that student would take up that clinical hour space. And in order to be most efficient, I want to, and be a good steward of that money, I want to use those clinical hours to the max. So one of the things that we did was reduce the attendance. Reduce the session limit and tighten the attendance rules so that more students could be seen. but we also set up a different scheduling model so that students who needed more flexible scheduling could also be seen. This a chart right here also shows our student success data based on, against the number of counseling sessions that students come to. Obviously, most students don't come to counseling and they graduate at an 80% rate, but you can see just with one session, it's not that many people, so the N isn't comparable, but the graduation rates are higher. Being able to show the university that means we're worthwhile to invest in. I can also see that around 8 sessions, which was our average session amount anyways, the graduation rates aren't that much significantly higher after that because not as many students come to that many sessions. So we've changed to an 8-session model limit, which has helped our waitlist and allowed more students to be seen. The next thing is scheduling with efficiency. This was probably, I think, the most important thing we were able to do in order to see more students without increasing clinical hours is fancy scheduling. When I first got there, I tried having counselors schedule themselves with the people they met with on walk-in. They scheduled themselves, yeah. Anyways, I dropped that and moved to centralized scheduling to maximize the clinical hours. Counselors are counselors. They feel for people and they might not adhere to the attendance as you would like, or might schedule for longer than you'd like, or just have not consistent ways of doing things. The centralized scheduling was a big thing that changed our efficiency. The other thing that was the big thing that changed our efficiency was using a scheduling rubric that had both weekly and bi-weekly scheduling based on the urgency level of the student. And what we did first was had some hours were weekly slots, some hours were bi-weekly slots. This is when we offered 15 sessions and we would schedule in 5-session blocks, because again, you don't want to schedule 15 sessions all the way out when you know the student might not need that or might not come to those. So that just clogs up the schedule. If you schedule in blocks of 5, in the first 5 we scheduled were weekly for everyone. Because we know research says this, if you're going to change, it's probably going to happen close to the beginning. All right, so hit it hard in the beginning. After those 5 sessions, we moved to a bi-weekly scheduling model. But what that means is they also changed times to a bi-weekly slot. What that ensured was that about every 5 weeks, a new slot or new time slot would open so that another student could get in. This is what allowed continuous flow in the system without it just getting, okay, everybody schedule up now and for the next 4 months, we're done. I talked about the attendance and here's another key. So at first, I had all counselors do walk-in shift. And with the number of students that we were having coming in, let's say we're averaging 50 new students a week, we're not opening up 50 new slots a week. And I also wanted to expand services to be able to support students who weren't going to come to regular visits, didn't need them, and who could use I pop in here and there. In order to do that, but I couldn't do that with our existing framework because the scheduling was so tight and rigid. In order to make sure that we're using these clinical hours efficiently, there was no room to schedule an odd visit a month from now because there'd be already somebody in that time slot. What I've done in the last 2 years is split the staff. So there's counselors who do the individual therapy and there's counselors who do the shorter term therapy, the care consultations, and the initial consultations. That allows for regular scheduling to happen over here and this more flexible scheduling and pop in, walk in to happen over here. And that's been very successful as well. Another recommendation would be to hire smart. If I had, so I've built this team from the ground. There was only me and the director. The first hire I did was a crisis care coordinator and a case manager, a client advocate. The crisis care coordinator takes care of the urgent matters that happen that because of the regimented scheduling, I don't have counselors that can just stop what they're doing and tend to the crisis emergencies, or someone to make sure that they were able to consult with the counselors and take care of students that were being hospitalized or students that were being reported as students of concern by other campus partners. The case manager, client advocate, we're not the counseling center is not a hospital. It's not geared to treat every problem. And it's irresponsible in some ways to say that we could. Just like the health clinic they send people to the hospital if they need heart surgery. They don't just give them blood pressure pills. It wouldn't be right. So we have to refer some people out to more intensive care or a different specialized care. However, in order to streamline this and to make it most helpful and effective for students, I hired someone, and that's her job. She meets with students individually and works with them to find resources in the community. And she also sees them bridge until they get connected to that community provider. The varying levels of degrees and license types based on task. When I first got there, I'm a psychologist. The director was the director at the time was a psychologist, and the RIF, everybody was a psychologist. Well, psychologists are really expensive, actually. And what research shows is the type of degree you have isn't what is correlated with outcomes. So we opened up who could be a counselor. So we still have licensed counselors there, but they're licensed in all, licensed professional counselor, licensed marriage and family counselor, licensed clinical social work. And that gave us more room to hire and also a more diverse kind of offering. I've also in the last year started to hire provisionally licensed counselors. So counselors who had taken their licensure test but needed to finish hours. That means they've already gone through practicums, they've already passed the licensure test, they just need to gain more supervised hours. And this staff, I can pay less and offer them supervision, which they would have to pay someone to get outside of here. And they are in charge of doing my intake and my shorter term counseling services or more flexible counseling services. I don't recommend necessarily using practicum students to do intake because you don't know who's coming in at that time. And so I don't want to put my least experienced person on the most stressful place. However, what that did is allow me to spend the money more efficiently and have more staff. The other thing, we have a mix of full-time and contracted staff. At first, all the staff was contracted. It doesn't work totally because you need administrative coordinating roles. So we had full-time administrator, the full-time care consultation, the full-time case manager, and myself as the coordinator, the associate director, and the director. Okay. But the contractors were providing a lot of the bulk of the clinical hours. And why did we do that? Because full-time staff, they got to eat lunch, and the way you schedule notes times, and they often get tasked with coordinating roles, or they have to do outreach. And so all of their time, about 62% of their time ends up getting used for straight clinical hours. However, contractors, which I schedule on at a 3:1 kind of ratio, 3 clinical hours to an hour of progress notes. And that gives me a 75% use of clinical hours from their time. So 62 to 75, that ends up giving me a lot more clinical hours without more staff. Finally, I think, making it easy with existing technology. You want to make it easy for students and really easy for your staff to get stuff done and to, to be more efficient with the processes. I think sometimes we have meetings that could be done by other means. We take time sending the same emails to people by having to copy and paste this, or it takes time for the front office to figure out after someone calls and we need to send them the link to take the intake paperwork. That means they have to stop what they're doing and send the email. Well, I've been able to automate a lot of student contact and contact with other campus partners by using automated workflows. This little picture over here is what Microsoft suite of apps. And all I did was say, I wonder what they do. Power Automate is the way that I automate tasks. And what that means is I have forms that people fill out, let's say the front office contact form. And this is what this picture is here. When a student calls, these are the options that the front office staff will basically check off. Depending on what they check off in the form, they have branching to say, what do you ask next? And depending on what they click through, automated emails and alerts are sent to the people they need to go through, which makes it take less time. They don't have to call the counselor to let them know there's somebody who needs a crisis. It automatically sends them an alert. They don't have to send emails letting students know that what our resources are, because when they call, I have it set up to automatically send the student resources. And all the front office is doing is putting an email address and clicking through a form. As you want to make notes, as much click template as you can, especially let's say the intakes, and also for contacting students. After every absence, we send a student an attendance email. Instead of having your counselors make that up, make a template. We have templates that I send to urgent students after they come in, templates, different ones that we send to routine students that they come in. And all the intake counselor is entering is their name and their email address, and that kicks off this state. So you want to make things that have minimal data entry, which can really do more complex response needs. How has this ended up for us? Our center productivity, this starts at 2017 and this is 2020. You can see that I think that we're doing a lot of appointments for my 16 FTE. That's a pretty good amount of appointments, and I feel good about our productivity. Our student satisfaction ratings are high consistently, and I'm committed to that and bank on it. And if they drop low, I'd be concerned. Also, our student outcomes. Just to let you know that this blue line, the black lines here represent national averages. We participate with our EMR in the CCAPS assessment, which means that we're in a pool with 270 other universities that are also giving the same assessment to their students. So they get on the symptom indices, there's a national average, which are the black lines. As you can see at intake, which is pre, our students are have higher symptomatology on the indices than the national average. But as you can also see, we have more treatment progress than the national average too. So at the post symptomatology is lower than that of the national average, which is pretty cool. So I think we're doing our job. And that's it. That's what I got. That's the end. Again, my name is Makita. This is my email, and I do provide consultation services. So if anybody wants to know more or have a personal talk about how to work things out in their center, that's something that I can completely do. And that's it.
Thank you so
Yes.
much, Dr. Dougherty. I think that was great. You shared so many things that can be implemented tomorrow and for years to come. So
Awesome.
I really appreciate it. I want to turn it over to Lily to queue up our communities of practice time.
Okay, wonderful. Yeah, thank you so much, Makita. That was great. I was trying to
Sure.
take some notes, and especially that technology slide that you had up there at the end. I was really interested in how those different Microsoft tools kind of play together. So like the forms to the Power
To the
Automate.
SharePoint to the Power Automate.
Yeah, wow.
You want to mess with that.
Okay.
And I'm not a computer person. I just knew that I can't do this by myself. I can't keep up.
Right. Yeah, some of those efficiency and operations pieces could probably be one opportunity for helping campuses scale. So the next phase, and we've got about 30 minutes left of the meeting today, we're going to break into 3 rooms where we'll be able to just kind of talk with one another and think about what we've heard today and how that might apply or help us with the scaling of services on our own campuses. So why don't we go ahead, and it might be best just to do 2 rooms. So we could have Makita and myself, and then if Beth, Phyllis, and Melanie want to be in the second room, that'd be great.
Cool. The rooms will open for 25 minutes and then it'll count you down to come back. Here we go.